one of the American oncologists stood up in the audience and said, "Why aren't we doing this everywhere?" And Dr. Hall very politely, as a British man, said, "Oh, well, I don't know. You don't have this in America." And I said, "That's actually not acceptable or true. We do have this drug in America. It's just not in the same formulation. And we have it for a different indication." And I realized that oncologists had never heard of it. It's a risky time for your breast. And so what the anti-progestins do is they keep your breast before the preparing for battle, before the huge event. And that's protective. The reason why this medicine is not used often is entirely a bias that we have perpetuated based on when sex happens and what sex we as a society think is acceptable. We should have no concerns about this medicine increasing the risk of breast cancer. All people that have breast cancer that have contraceptive needs should be having conversations about this medicine.
Hi, everyone. Welcome back to Kicking Cancer's Ass at Rise Up 2026 for breast cancer prevention and women's health. Last year when I was here, I went to a poster and I met this really energized, excited, young OB-GYN. I'm going to let her tell you the name of her institution in Oregon so I don't screw it up. But Dr. Abigail Liberty is back today and was on the main stage. And we are going to talk about the relationship between emergency contraception and breast cancer prevention, because she's got a lot to say there. So welcome. Tell me a little bit about what brought you to this work and where you work so we can get that in.
I work at OHSU in Portland, Oregon, and I'm an OBGYN. I did my 4 years of surgical training, and then I did 2 additional years in subspecialty training in a field called complex family planning, which includes abortion and contraception. And I was the first class to be in training during Dobbs. And so that really sort of shifted the priorities and the conversations and who we were treating, and seeing a lot more people who were really ill presenting for abortion care due to delays in their home states. But throughout my whole life, I've sort of been interested in this controversy about how contraception affects breast health, because I remember being a young woman and being told that I had to make a decision and I could choose hormonal contraception, but there could be a risk of breast cancer associated with it. And as a young person, that feels really abstract. But it also feels like one of the first times you're forced to choose between these parts of your bodies and medicines that might protect some and align with my goals, but also at the cost of maybe hurting others. And what I really wanted was better science about this. And so I got a grant to study that.
Before we get started, I want to thank Paxman for making this episode possible. When I was going through chemo at UCSF in 2023, I used Paxman's scalp cooling system, and it worked. I kept my hair when I thought I was sure I'd lose it. That mattered more than I expected it would. It's the same technology that's helped tens of thousands of cancer patients worldwide over the past 25 years. Because of Paxman's sponsorship, we can share the research and insights from the UCSF 2026 Rise Up Conference with you. So if you're facing chemo and want to explore scalp cooling, visit coldcap.com. Link will be in the show notes. Let's get back to the episode. And it's interesting because I remember I'm quite a bit older than you, but they said, well, the oral contraceptive, hormonal contraception could reduce your breast cancer risk, or it could increase your breast cancer risk. And you're sitting there and you're like 19 years old. I was actually younger because I was having very painful periods. And you're like, how do I even process that? So I'm very thankful that you keep doing research. And let's talk a little bit about this new area, which isn't that new, but tell us a little bit about anti-progestins, emergency contraception, and how this relates to breast health.
So 2 years ago, I was at a conference for prevention, and there's not a lot of them. This conference is pretty unique in that, but this one was in Manchester, England, and I saw Dr. Sasha Howell present his work. And he was saying that they used a medicine that we've never had in the United States for complex reasons, that's used for fibroids. And they took that medicine and they applied it to breast health. And that's a medicine that blocks progesterone. And in general, breast health focuses on estrogen, but there's this new wave of scientists and oncologists that really think it's the progesterone that's the risk factor. And there's a lot of evidence for that from the menstrual cycle and aging and pregnancy. And at this talk, at the end of it, when he shared that he found the significant reduction in the cells that go on to become cancer and significant protective changes in the supportive scaffold around those cells, one of the American oncologists stood up in the audience and said, "Why aren't we doing this everywhere?" And Dr. Hall very politely, as a British man, said, "Oh, well, I don't know. You don't have this in America." And I said, "That's actually not acceptable or true. We do have this drug in America. It's just not in the same formulation. And we have it for a different indication. We never had it for fibroids, but we do have it for emergency contraception." And this is a medicine that I'm very comfortable prescribing, that I prescribed every day when I talk to people about their pregnancy risk and their family planning goals. And I realized that oncologists had never heard of it.
It's interesting. I had a breast surgeon who's become passionate about exercise oncology on. And he said a very similar thing about exercise, where he said the kinesiology world has known for 30 years. They have the data that this reduces cancer risk and improves response, and the oncologists never knew. So it's the same with these drugs. So what were you prescribing them for, and how do they work?
Exactly. So this drug, which has been available for 20 years in the United States, is a progesterone receptor modulator. So I tell people it is like tamoxifen, but instead of targeting the estrogen receptor, it targets the progesterone receptor. And for a lot of people, they understand that, and that's intuitive, which really speaks to how breast cancer treatments have become a sort of common parlance among people. And what we use it for in the United States is to prevent conception after somebody has had an exposure, which means exposure to sperm, which could increase the risk of pregnancy. But it will only work if they have not yet ovulated. And so what the medicine does is if you take it after what we call unprotected sex, which can be a problematic term, but if you take it after unprotected sex, it stops your egg from being released for exactly 5 days. And that time period is critical because sperm can live in the body for that long. And so when you can delay that meeting, they never meet and you don't get pregnant.
Okay, so I understand it from an emergency contraception. Great. Now help me make the jump to what does that have to do with how something like that could help breast health? Because we have fibroids and we have Dr. Sasha Howell on the podcast as well, but we don't assume that everyone's listened. So please give us some education.
So I think the best way to think about how this affects the breast is to think about the menstrual cycle, which is my love language as a gynecologist. And so in the early part of the menstrual cycle, or in cycle day 1, you're actually bleeding, right? Your period just started and your estrogen levels are low and you have no progesterone. And then slowly within your ovary, it starts to make more and more estrogen, preparing your body to ovulate. And at that time, the breast cells, they go from looking like a single, like condensed lobe to 2 layers. You can suddenly see those myoepithelial cells and the epithelial cells. And then in the menstrual cycle, they're all competing. One of them wins in this beautiful sort of Machiavellian race. And when it wins, it forces the rest of them to make progesterone. To prepare if a pregnancy happens, they have the reserves. During that time that they're making progesterone to prepare for pregnancy, they are building all of this machinery. They are swelling. They are inviting in immune cells. They're just getting ready for a big change, preparing for battle, right? And the cells look different under the microscope. And then what happens when you are not pregnant is your body has to go in and break down all of that and clean it up. I think of it like cleaning up after a football game or an Olympic event, right? And there could be mistakes. It's a risky time for your breast. And so what the anti-progestins do is they keep your breast, when you take them regularly, in that state before the preparing for battle, before the huge event. And that's protective.
It's very interesting because you don't know this about me. I had my ovaries and fallopian tubes out when I was 38. I did have HRT. And at one point, one of my doctors decided to try some estrogen. And I had I think a mammogram ultrasound within 4 weeks of that. And I had the same wonderful radiologist for 20 years. She actually is one of my early guests, Dr. Harriet Borofsky. And I remember her calling me and saying, "Joelle, what did you do? Because your breasts have been calm for years and all of a sudden they're lit up and I don't like it one bit." And I said, "Oh, well, they did a hormone replacement with estrogen." She's like, "Yeah, I'm not a big fan." And I then said, "Doctor, talk to doctor." So is what you're describing, and by the way, never did I get estrogen again, but is what you're describing that calm look on a mammogram ultrasound where, the breast's just kind of hanging out, it's not doing anything?
Uh, yes, it's a little bit more nuanced. So
Okay.
estrogen can induce proliferation, right? That's where the cells go from being this sort of condensed circle to having two layers. Estrogen does cause this proliferation and this slight growth, but it is different than the edema and the activity that we see associated with the luteal phase of the pregnancy, which is reflected in people that say, my breasts hurt right before my period. Right. And they know it's coming, or an early pregnancy where people know that they're pregnant because they're having these breast symptoms. That's all progesterone mediated. And it's likely inflammatory rather than sort of proliferative. So they do both affect the breast in different ways. But I think progesterone is having this larger effect during the reproductive cycle.
Actually, and by the way, I love that you just called the menstrual cycle your love language, because most of us are like, ugh. We needed to have children, but they call it the curse. But you used a word just now that is kind of a trigger word, which is that it was inflammatory. And I know in the longevity universe, but also in the cancer universe, there's a lot of attention on inflammation. Is this anti-progestin another attempt to reduce inflammation in the breast so that we have less? If inflammation has some correlation to cancer, and you can probably explain this better, is that kind of how the scientific theory is working?
I think it's a potential mechanism, but I don't think we have the full data for that yet. So what the study by Dr. Howell showed is that when people take progesterone daily, which is not the dose we have in the United States, they stay in that sort of quiet early menstrual-like phase, the sort of follicular phase. And the breast cells during that time are not as active, and they don't have all of that machinery that breaks down cells, and that machinery that breaks down the extracellular debris and things like that. Those are immune cells, if that makes sense. So when you're preventing that cycle, you have fewer immune cells coming in and going out to clean things up. But the other important thing that they showed is that we often talk about the stress, another trigger word, on the cells themselves. And there's increasing evidence that a very stiff environment around a cell is stressful, both for the immune cells, but also for the epithelial cells. And so one of the things that his study showed is when you give this anti-progestin, the tissue itself is less firm. Not in a way that causes saggy boobs or that you would ever notice, but in a way that lets your body actually more efficiently access cells and get to them. And we think, get rid of the cells that are dangerous, that your body can clean up on its own, fix problems that come up. And so we think it's probably through a tissue remodeling, both of the cells that grow and the space outside of the cells.
It's actually fascinating. Like the whole thing, and thinking of it structurally and what the impacts are is just fascinating. So I asked before we started recording that we said we were going to go here. Like, why are we not pursuing this heavily, at least for research? But why don't we have the dose that helps women with fibroids, which is a very life-altering negative experience? What's wrong with us here in the United States?
So I think there's sort of three components to that. So the first one, which I talked about yesterday with the whole group at Rise Up, is that people treat emergency contraception differently than what we think of as regular contraception. And that is entirely a bias that we have perpetuated based on when sex happens and what sex we as a society think is acceptable. And that's not appropriate for people that are just trying to reduce their risk of a pregnancy. So the first thing is the reason why this medicine is not used often is if you've had sex and you realize you might be at risk of pregnancy because a condom broke, or maybe you weren't planning to, or maybe you were taken advantage of, which is assaulted, call it what it is. Yeah. It's really hard to get in to see a doctor and get this medicine. There are over-the-counter ones available, but those aren't the ones that have been shown to be protective in breast cancer. The one that has been shown to be protective, you need a prescription for. So the first reason why these medicines are not, why UPA is not widely acculturated in America is because of biases we have about post-coital contraception, or ways of preventing egg and sperm from meeting after sex has happened before they've met. The second one that's related to that is that UPA is from a class of medicine that blocks the progesterone receptor, and other medicines that block the progesterone receptor have been used in abortion care. and they're used for medical management of miscarriage and medication abortion. And so anything that can be potentially used to help somebody safely into pregnancy are highly regulated in this country. And there's a lot of bias and barriers, artificial structural barriers to accessing them, because people that are against abortion don't want anybody to be able to use any medicine to end a pregnancy. So that's the second barrier. The last barrier, which is related to the first ones, is that in Europe, they had multiple studies, the Pearl studies, that showed that these are incredibly effective at preventing the bleeding and morbidity associated with fibroids. And these were doses that were taken every single day. And what they found once they were approved, so in the clinical trials, they were safe and approved. And when they went to market and hundreds of thousands of women were using them, there were several cases of what we call idiopathic liver injury. And these, some were fatal and some required liver transplant. So these are really big deals. And that was the argument for reducing it from the market. However, DILI, which is the drug-induced liver injury, happens with other medicines, right, when they've been released. And it happens in other medicines, for example, common medicines for UTIs like, nitrofurantoin, common antibiotics like amoxicillin, Augmentin. These have the same frequency of DILI as UPA, but they're not pulled from the market. And one of the reasons is because the government say, well, fibroids aren't an illness the way a UTI is an illness, right? So this is a bias that we have against what are considered benign, meaning just non-cancerous conditions that women have, that we expect women to tolerate. And medicines that are used for that, to ameliorate those, are held to a higher standard than medicines that are used for indications that we consider socially acceptable, like UTIs. We think that the reason why people devalue these even further is because of the association with abortion.
Okay, so it's infuriating that any non-physicians are determining what constitutes a medical condition or not. And the idea that, I don't have fibroids, thank God, but listening to some of the advocates here talk, that is a disabling condition when you have serious uterine fibroids. And the answer a lot of them get is have a hysterectomy, which has profound impacts on your body, the chemistry, your sexual health, everything. So it's insane. I'm sure you think it's insane, but I'm a layperson saying, that's insane. And the concern about being potentially effective to help with an abortion, a medical abortion, I think when I talk to people that are pro-life, which I think is, I actually call it forced pregnancy. When I talk to the forced pregnancy crowd, the idea is to prevent unwanted pregnancies so that we don't have to have abortions. That would be great. Don't we want drugs in the market that do that? I know you agree. Okay, off my high horse. You mentioned in your talk that this drug, UPA, is actually not in every pharmacy. Mm-hmm. And you just said to us, it's hard to get into your doctor fast enough. Mm-hmm. So what is your recommendation for people who want to have this option? And, we'll get to the breast cancer question in a moment.
So we have excellent evidence from studies around the world that support this idea of advanced provision. And that's an idea where you should be prescribed and have access readily available to emergency contraception before you ever need it, if you ever need it, even if you never need it, right? And what the studies show is that when you give people emergency contraception, it does not decrease how often they use condoms. They use condoms at the same frequency. It does not change their sexual activity. They're not having more sex or sex with more people. The only thing it does is reduce the time from when they identify their risk to when they take the prophylaxis, which is the most critical time.
And frankly, I think it would give women, unfortunately, there are women who are assaulted, and whether it is date rape or, a assault, what have you, which is full of shame and fear and whatever else, and to have that in your bathroom, that you still have to deal with everything that happened, but you don't have to deal with an unwanted pregnancy on top of it. So I think it makes a lot of sense.
I was just going to say that lots of people use barrier methods, condoms, or other pericoital methods like spermicide or pH modulators or withdrawal. And these are the exact people who we know benefit from having UPA emergency contraception available, because those methods have, they're a little bit more difficult to use. And so this is an extra tool for them. But I would say even if you have hormonal contraception that you're using, it's worth talking about with your physician to get it in advance in case you need it.
With the exception of the hormonal contraception that is embedded, right? When you have to remember to take it, there are times where people are not as compliant as they might have hoped, and they know they weren't as compliant. Then they're having sex, maybe with a partner they trust and what have you, and you're like, this, I need an extra insurance. So do you think we're going to get to a place where we'll study UPA in the United States for breast cancer, or are we just going to continue being too puritanical, too worried about, it's not even a use case, it's prescribed for abortion. But, do we think that that's a possibility, or are we going to just watch what they do in Europe and hope?
So I think we are watching Europe closely, because when we justify this to the regulatory bodies, we will have to cite those studies, and that'll make it stronger. So I think it's incredibly important that we continue to collaborate internationally on this work. But I think there are studies we can do here. And the first study that I think we need before the big lift of getting those lower doses that were used in Dr. Hall's study is to see whether the dose that we have available in emergency contraception can also be used, right? It would be a different dosing regimen. It might be shorter periods, things like that. But that's a study we can ask right now. How can we use this dose that's already available in these off-label ways to sort of replicate what we see abroad? And then on big pharma. And then after that, how can you put pressure on pharma to engineer the drugs that we need?
Yeah, pharma, if it sells, they're going to figure it out. So, all right. So my last question, I ask everybody, and I know this is slightly outside your love language, but what's your advice for anyone who's looking to kick cancer's ass?
So I think for people that still have the ability to achieve pregnancy, even if whether it's desired or not, it's incredibly important to have this medicine available, because we should have no concerns about this medicine increasing the risk of breast cancer. And so really all people that have breast cancer that have contraceptive needs should be having conversations about this medicine with their care team. So that's the first thing. The second thing is that as we are in a country that is facing stigma for abortion care and contraceptive care, the people that are most likely to be hurt from that are people that have cancer. And that's because these medicines are not being applied to them. And there is excellent evidence that these medicines can help. They help in ways sometimes that are really difficult to talk about. So there's some evidence that in refractory disease, these medicines are palliative. They can reduce the pain, maybe through inflammation, we don't know, that people are experiencing, and that is still valuable. Mm-hmm. And so I would ask everybody who is facing and fighting breast cancer to think about, how do you feel being denied these medicines, regardless of how you feel about emergency contraception or abortion, and recognize that we probably have common goals in just giving people options and information and trusting people to make the best decisions for themselves.
I love it. Thank you. Thank you for being on Kicking Cancer's Ass. Thank you for the research. I am hopeful for my daughter, for my niece, for so many young women that, they should all go. Actually, I have to ask you this question. What medicine should they be asking their doctor for?
So I would recommend that everybody ask their doctor for advanced provision of Ella. And Ella is the trade name of UPA, or ulipristal acetate emergency contraception. It's the 30 milligram dose that you can take up to once a month to prevent pregnancy.
Okay, so everybody who's listening who is a woman, or somebody who was a woman and has women's reproductive capabilities, or is the mother of someone who has said description, this should be with your college kids, this should be with your daughters, this should be in your in your own home pharmacy. Does it expire? Do you have to renew it every year or 2 years?
It does expire over time, but that'll depend how the shelf life will be on the medicine that you get. But it will not be something that expires in a month or two. So the more we get it, the more we manufacture, the more the stock is turning over, the more we have it.
Okay, so we'll put a link in the show notes to Ella so people can know what they're talking about. And, it's a good, safe, It's approved for this use, and you're simply taking control over your own reproductive life. And hopefully we're going to learn that it's also going to help with breast cancer, but we're not there yet. Thank you for being on Kicking Cancer's Ass.